I will discuss about the lymphoreticular system, mostly the lymph node diseases. I am Professor Moinuddin for your review class. The lymph nodes are encapsulated kidney shaped organs composed of lymphoid structures. They are found all over the body, mostly along the great vessels. Each lymph node have outer cortex and inner medulla. So, if we divide the lymph nodes, then the cortex containing the lymphoid follicles and the paracortex mainly contains the T lymphocytes, dendritic cells, which is antigen presenting cells, and medulla contains antigen secreting plasma cells. Sinuses, cavity or the sinuses containing the macrophages. You see the lymph nodes, these are the primary follicles and these are secondary follicles and paracortical areas, and these paracortical areas are T cell reached, and the secondary follicles are in the center, that is the centrocytes and centroblast, and the surrounded a zone, the resting B cells. So, the lymphocytes developed in the central lymphoid organs, B lymphocytes in the bone marrow and T lymphocytes in the thymus. Then after their initial development, lymphocytes circulates through the blood and under the influence of specific cytokines and chemokines home to the lymph node, spleen, tonsils, adenoids and pair of patches. The activation of the resident lymphocytes into the peripheral lymphoid tissues leads to morphologic changes in the lymph nodes, forming primary follicles, and within several days of antigenic stimulation, the primary follicles enlarge and develop into a germinal centers. Germinal center contains a reactive B lymphocytes, which is surrounded by a collar of resting B cells termed as mantle zone, and germinal centers containing the reactive B cells are capable to produce antibodies against specific antigens, and paracortical T cell zones may also undergo hyperplasia. Degrees and pattern of morphological changes are dependent on the inciting stimulus and the intensity of the stimulus. So, the infections and inflammatory stimuli causes stereotypical pattern of lymph node reactions designated acute and chronic non-specific lymphadenitis. Then we can divide the lymph node diseases into acute non-specific lymphadenitis, chronic non-specific lymphadenitis, and then chronic specific lymphadenitis. And another is most important is malignant neoplasm of lymph nodes. Mostly the lymphoma and secondary the metastatic carcinoma. So, the chronic non-specific lymphadenitis have three patterns: follicular hyperplasia, paracortical hyperplasia and sinus histocytosis. The follicular hyperplasia caused by stimulation of lymph nodes that activates the humoral immune response. It is defined by the presence of large germinal center, which is surrounded by a collar of resting small lymphocytes, the mantle zones, and the germinal centers are normally polarized and containing mainly two types of cell, centroblast and centrocytes. Now, you see the pictures, the prominent germinal centers surrounded by a mantle layer of zones. Then you find the another slide is in case of reactive lymph nodes, we usually report as polymorphous lymphocytes. That means the lymphocytes of variable stages of developments and the histiocytes along with the tingible body macrophages. You see the tingible body macrophages here. These tingible body macrophages, the macrophage engulf the lymphocytes, macrophage engulf the dead degenerated cells, macrophage engulf the foreign particles, macrophage engulfs the disintegrated neutrophil also, and at the same times you will say this such types of increased mitosis also there. So, in case of reactive hyperplasia, then it comes the chronic specific lymphadenitis. Here we know the specific cause, as for example, the Mycobacterium tuberculosis causing caseating granuloma, at the same times the non-caseating granuloma by the syphilis, filariasis, sarcoidosis, cat-scratch disease and other causes also causing the specific lymphadenitis. Features favoring a reactive hyperplasia includes from the neoplastic, that preservation of the lymph node architecture, that means the follicular structures, interfollicular cells, T zones, marked variation in the follicles in the shape and size, and presence of frequent mitotic figures, phagocytic macrophages and recognizable dark and light zones. These are different from that of the neoplastic changes. So, what we see in the neoplastic lymph nodes? So, the first we say the nodal architecture is completely effaced, that is there is no cortical or medullary structure. So, effaced, but in case of reactive hyperplasia, the preservation of the lymph node architectures. Then paracortical hyperplasia is caused by the trigger of the T cell mediated immune response, as for example, acute viral infections, infectious mononucleosis. Paracortical region contains activated T lymphocytes, which are 3 to 4 times larger than that of the normal lymphocytes. Then another variety is of reactive lymph nodes is a sinus histiocytosis. What happened? It is also a non-specific forms of hyperplasia, may be particularly prominent in the lymph node draining cancers, as for example, carcinoma of the breast. The lymph node endothelial cells are markedly hypertrophied and macrophages are greatly increased in number, resulting in the expansion and distension of the sinuses. Then we move a definite pictures. In the Japan, a statue is written, your weight value is not on the number of kilograms or size, but the number of book you read. So, your weight depends upon the how many books you have read. Then moves for another. So, another slides causes the lymphadenopathy. So, the one cause, important cause is the bacterial infections. It may be bacterial, it may be fungal, it may be viral, protozoal, helminthics. So, the most common one in our country is the bacterial tuberculosis, and it also occurs in case of syphilis. Viral infections caused by cytomegalovirus, measles, infectious mononucleosis, HIV infections, and fungus also causes lymphadenopathy, histoplasmosis and coccidiosis. Protozoal infections such as toxoplasmosis, helminthic infections occurs the filariasis. and the malignant disease, the lymphoma, leukemia and metastatic disease. So, what are the other diseases where the limb adenopathy occurs? Connective tissue disorder, as for example, SLE. In case of sarcoidosis also lymph adenopathy occurs, and in certain drugs, as for example, phenytoins, carbamazepines, these drugs also causes lymph adenopathy, lymph node enlargements. Then how will diagnosis? A case of lymph node disease, it is a inflammatory or it is a neoplastic or it is a other causes. So, firstly we do the fine needle aspiration biopsy and then proceeds for the lymph node biopsy. Then another possibility is the bone marrow aspiration and biopsy. If these three sometimes is adequate for the diagnosis, but sometimes may confusion arises, in that cases immunohistochemistry is also needed. Flow cytometry, and in Western Europe also the molecular genetic studies, fluorescence in situ hybridizations is also important along with the cytogenetics. So, you may ask what are the indication of biopsy? So, biopsy, why you send the patient for biopsy? So, indication is increase in size over the baseline in more than 2 weeks. So, no decrease after treatment in 4 to 6 weeks or no regression to normal 8 to 12 weeks and development of new sign and symptoms. And sometimes we do biopsy indicated to confirm the diagnosis given by fine needle aspiration cytology, FNAC. So, FNAC is the provisional diagnosis and then it is confirmed by biopsy. Now, you see a lymph node pictures shows the multiple reactive follicles in different size. This is follicular hyperplasia, as because the lymph node, the follicles are variable in size, shape, and within the cortex they maintain the cortex and medulla. Then this slide is a epithelioid, that is a granulomatous inflammations. In the class, I usually ask you that what is granuloma? It is very easy questions and easy answer, but if you do not answer these questions, then the examiner will very much mind. So, in case of granuloma, the one thing is very clear, the focal collection of epithelioid cells, it qualify the quality of a granuloma. Then you give some ornaments. So, the focal collection of epithelioid cells surrounded by a layer of lymphocytes and macrophages. So, these are ornaments, but the focal collection of epithelioid cell is sufficient to cause or sufficient to form a granuloma. So, it is a typical granuloma is here. So, this caseating granuloma is most likely it is a cause of tuberculosis. And then, so this you can see the slides, this is the larger epithelial cells, hyperchromatic nuclear cytoplasmic ratio is altered, and background there is a necrosis and lymphocytes. So, this is a malignant metastatic malignant tumor, most likely the tumor is a adenocarcinoma, as because the malignant cell forming the acini. So, metastatic epithelial cells, so metastatic adenocarcinoma in the lymph nodes. Then another slides you see the lymph node shows the metastatic ductal epithelial cells. So, definitely not benign, it is a malignant ductal epithelial cells forming the granular structure, it is a malignant ductal epithelial metastatic carcinoma. Another is a foci of it is a squamous cell carcinoma, metastatic squamous cell carcinoma, and it is clear having the keratin pall also. So, now we will discuss about the lymphoma. So, first you will ask, what is lymphoma? Lymphoma is defined as malignant proliferation of cells native to the lymph nodes. It is solid malignancy of the lymph nodes. Many lymphomas are known due to the specific genetic mutations, and the lymphoma can be divided into Hodgkin's lymphoma and non-Hodgkin's lymphoma. Both groups are further subdivided to several distinct subcategories. Then another slides you are saying that Thomas Hodgkins, that gentleman's first described the Hodgkin's lymphoma, and in the sides, by the sides you will also see a pictures having the enlarged axillary lymph nodes, cervical lymph nodes, and periauricular lymph nodes are enlarged. So, if we want to diagnose a case of Hodgkin's lymphoma, then we have to first find out the red Sternberg cells. What is red Sternberg cells? It is a multinucleated giant cells, and it is described by in 1980 Sternberg and Reed Saib in 1902, curable in many cases, long term survival of chemo and radiotherapy. Predominantly, epidemiology, if we say, male are more sufferer than female, white are more sufferer than the Asians, and about 40% of malignant lymphoma is the Hodgkin's lymphoma. No clear risk factors, but several factors are implicated in the disease of Hodgkin's, as for example, Yps tenvier virus, HIV, woodworking farmers are suffer much more than that of the others. So, clinical presentation is a non-tender lymph node enlargements, neck and supraclavicular glands, and mediastinopathy, mediastinoadenopathy, mediastinal lymph nodes. And WHO classifies, recognizes the 5 subtypes of Hodgkin's lymphoma. First one, the most common, the nodular sclerosis, and the next is a mixed cellularity, lymphocyte rich, lymphocyte depletion. These 4 categories recognized as the classical form of Hodgkin's lymphoma, and the 5th one, the lymphocyte predominance, is another type having the B cell immunophenotyping, and the differs from that of the classical Hodgkin's lymphoma. Nodular sclerosis varieties, most common, constitute about 60 to 70% cases, and both male and females are equally infected, that is affected. Fibrotic capsules and bands of subdividing zones, and having a typical, you see the typical, that is the lymph nodes having the red Sternberg cells, and sometimes the lacunar variety. And very interesting, the CD, if you do the immunohistochemistry, CD15 is positive, CD30 is positive, but Epstein-Barr virus is usually negative in case of sclerosing variety What happened in the other variety mixed cellularity, though the incidence is low, that is constituting about 20 to 25%, but more extensive disease and more common in the male and associated with the older age. And it is a mononuclear variants, you see the picture, mononuclear variants of RS cells, heterogeneous infiltrate, which includes T cells, eosinophil, plasma cells, macrophages. So, background there is a varieties of mature lymphocytes or other leukocytes. But in immunohistochemistry what happened? CD15 is positive, CD30 is positive and Epstein-Barr virus is positive. But in case of lymphocyte depleted varieties, what happens? The incidence is less than 5%. Pleomorphic RS cell is present. And again the most cells are positive for Epstein-Barr virus and also the CD15 and CD30 is positive in case of lymphocyte depleted varieties. What happened in the lymphocyte predominance varieties accounts for about only 5%. Lymphocytic and histiocytics variants of RBC and RS cell is present. Small lymphocytes are mixed with a variable number of macrophages. Eosinophils and plasma cells are usually scant or absent, but CD15 is negative, CD30 is negative, but CD20 is positive, Epstein-Barr virus is negative. So, it is a CD20 positive, that means it is a B cell origin. So, it is a B cell lymphoma. Again the lymphocyte rich varieties, mononuclear variants of red Steinberg cell is present, but CD15 and CD30 is positive and Epstein-Barr virus is only positive 60% cases. So, this is Hodgkin's lymphoma. Then we go for the non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma is most common here without any red Steinberg cells. So, no red Steinberg cells, no, so it is not a Hodgkin's lymphoma. And the vast majority, that is 85 to 90% of the neoplasm of Hodgkin's lymphoma is of B cell origin. And if you identify by CD, that is cluster degeneration determination. So, CD5 means the T cell type and CD20 positive means it is a B cell types. So, again the what is the cause? Still cause is not known, exact cause are still not known. However, a risk for individuals, that is chemicals, exposed to chemicals such as pesticides, solvents, infection with the Epstein-Barr virus, infections with the HIV. So, these are the candidates of a lymphoma, cause of lymphoma. Clinical manifestations show the systemic, the fever, night sweat, weight loss, anorexia. Local manifestations is lymphadenopathy, is splenomegaly, most common. Any tissue potentially be infiltrated in case of non-Hodgkin's lymphoma. So, the non-Hodgkin's lymphoma in the case diagnosis, key point is cell size is small or large, nodal architecture, it is follicular or diffuse. So, if the cell size is large, the prognosis So, aggressiveness is greater. If the nodal architecture is diffuse, this is aggressive. So, more aggressive is diffuse and large cells, more indolent follicular and small cells. So, the indolent is low grade and large, that is diffuse, usually high grade. But the aggressive tumors, rapidly growing tumors are more curable than that of the low slow growing tumors, indolent tumors. Next. So, classification of non-Hodgkin's lymphoma by WHO upgraded in 2008 stills. So, the upgraded classifications, the precursor B cell neoplasm, that means B cell acute lymphoblastic leukemia oblique lymphoma, and for peripheral B cell neoplasms, that is chronic lymphocytic leukemia or a small lymphocytic lymphoma. Then others are the Burkitt's lymphoma, diffuse large B cell lymphoma, plasmacytoma or plasma cell myeloma, follicular lymphoma, mantle cell lymphoma. So, all these are B cell origins. Again, the precursor T cell neoplasms is acute lymphoblastic leukemia oblique lymphoma. It is a precursor. If the peripheral T cells neoplasm is occurs, T cells prolymphocytic leukemia, NK cell leukemia, anaplastic large cell lymphoma, and then peripheral T cell lymphoma uncapsulated, and another is the mycosis fungoidosis or Sézary syndromes. Then we go for the frequency of B cell lymphoma. The very common diffuse large B cell lymphoma is the predominant variety, that is accounts for about more than 30% lymphoma is B cell, large B cell lymphoma, diffuse, and follicular lymphoma is about 22%, and multiple lymphoma is about 7%, and chronic lymphocytic leukemia or small lymphocytic leukemia is 7%. So, the about 70%, more than 70% lymphoma is these 4 varieties, and others are very small percentages there. So, the follicular lymphoma, most common form of indolent non-Hodgkin's lymphoma in the United States, and occurs in the middle age group and men female equally affected. Two principal cell types, you can see the small cells with cleaved nuclear, that is centrocytes and centroblast is present. And if we do the CD staining, immunohistochemistry, then it is CD19, CD20, CD10 will be positive. So, all these 3 CD19, CD20 and CD10 are positive for B cell origins. Diffuse large B cell lymphoma, we have seen that the most common, that is more than 30%, the one category is a diffuse large B cell lymphoma and most common form, and it express another is CD19, CD20, CD10, and the cells are usually large, 4 to 5 times the larger than the normal lymphocytes, and diffuse pattern of growths. And another variety is a Burkitt's lymphoma, African Burkitt's lymphoma initially, but it also the endemic Burkitt's lymphoma is occurring in the individuals infected with the HIV. Numerous apoptotic bodies, cells with phagocytosed macrophages and creating a starry sky patterns. So, sometimes it confused with that of the normal reactive changes. But if we do immunohistochemistry, then what we will find? Expressed surface immunoglobulin M, CD19, CD20, CD10 and BCL positive. So, you may ask how you will diagnosis in the laboratory of a lymphoma. Again, the fine needle aspiration biopsy, FNAC, excision biopsy and histopathology. Immunohistochemistry is very important in case of lymphoma diagnosis. What are the immunohistochemistry CD marker we used? CD15, CD13. If CD15 and CD13 are present, that is positive, that is positive for Reed-Sternberg cell. So, it is a non-Hodgkin's lymphoma, not, it is a Hodgkin's lymphoma. If CD20 is present, if CD3 is present, that is a T cell lymphoma. If CD45 or LCA is present, so it is not a primary tumors, leukocyte, common leukocyte antigens. Again, we need the karyotyping and cytogenetic studies. And recurrent molecular abnormalities are found in the lymphoma, as for example, the follicular lymphoma, translocation between 14 and 18, mantle zone lymphoma, translocation between 11 and 14, and diffuse large cell lymphoma, what we will find? The translocation between 3 and 14, and in Burkitt's lymphoma, translocation between 8 and 14, and anaplastic large cell lymphoma, translocation between the 2 and 5. So, this molecular cytogenetics is also important in the diagnosis of this non-Hodgkin's lymphoma. And then we will proceed for the clinical patterns. In the Hodgkin's, what we find? The lymph nodes are, you see in the picture, lymph nodes are the contiguous. So, continuous with the swarm group of lymph nodes. But in case of non-Hodgkin's lymphoma is diffuse, one lymph node, one lymph node, one lymph node, one lymph node, here lymph nodes. So, in case of Hodgkin's and non-Hodgkin's, the mode of involvement of the lymph node is different. And then another important is clinical staging to say the future of the lymphoma, to say the patients. Stage 1, you see the pictures, stage 1, that is only the one group of lymph node is involved, stage 1. If the two groups of lymph node is involved, then is the stage 2. Then stage 3, if the diaphragm, that is above the diaphragm and below the diaphragm, so the stage 3, and there is spleen that is deposits in the spleens. So, the both above and below the diaphragm is stage 3, and if the spleen, liver and various groups, then is stage 4. So, what are the benefit? Stage 1, stage 2, stage 3 and stage 4. Definitely benefit is, if the patient is diagnosed in the stage 1, the single lymph nodes where a contiguous lymph node is involved, then survival is more than 90%, 5-year survivals. If we diagnose, the patient is diagnosed in stage 2, then 5-year survival possibility is 70%. And in stage 3, the survivability is reduced to only 40% for 5-year survival. And if it is that stage 4, that is only 20% chance that the patient may survive up to 5 years. So, the important is early diagnosis. So, ultimately prognosis is Hodgkin's lymphoma is a curable malignancy. Overall cure rate is about 80% with modern therapy, and then ancillary studies immunoblast, that is CD15 and CD30 antigen in the Golgi and cell membrane of a RS cells. So, if you do the immunostaining, that is cell membranes and Golgi apparatus membranes is stained by the CD15 and CD13s, and so CD45 is do not take the stains, and this is a reactive lymph nodes. Another is, you see the picture, Reed-Steinberg cells, you see the typical Reed-Steinberg cells, দেখতে কেমন? প্যাঁচার চোখের মতো, owl's eye. So, other variants of Reed-Steinberg cells, it may be mononuclear, it may be multiple giant cell types, it also these types. So, the varieties of Reed-Steinberg cells. And then the last slides is large cell lymphomas. What are the cells or types? Large cell cleaved. These are large cell cleaved, and the large cell non cleaved varieties. These are cells, and the immunoblastic, that is plasmacytoid cells. Thank you to you all for your patience hearing.